everyone, this is Amanda Moore from the Angelman Syndrome Foundation, and you're listening to the ASF podcast, the show that explains everything you want to know about Angelman Syndrome. We're so excited you're here, and we hope you enjoy the show.
For this week's podcast, we're sharing a session from the 2024 ASF Family Conference. We hope you find this information helpful and enjoy the listen.
Well, welcome to the afternoon session. I know this is one that I always have loved to attend as a mom, especially since my sweet Jackson deals with seizures all the time. And so we're very, very lucky to have three of the best neurologists, three of the best humans within our Angelman space up here today to do a presentation for you all on everything epilepsy. And then when they are done with their presentation, there's mics up here. They will take whatever questions that you want to throw at them. But just to really quickly go down the line here, we first have Dr. Ron Thiebert, who is at MGH. Yes, so we got rounds of applause. Dr. Thiebert has been in the Angelman arena for 18 years. So he's seen quite a few individuals with Angelman syndrome. So we're very lucky to have him here. And then we have Dr. Robert Carson, who is at Vanderbilt University. Yes, see, everyone keeps clapping. Love it. Dr. Carson is also one of our amazing individuals that has been seeing our kiddos for a while, and also recently has taken on the really, I would say hard task, but really, really important task of trying to understand non-epileptic myoclonus and shaking and tremors within our kiddos and with our especially our adult individuals with Angelman syndrome. So he'll touch on that as well. And then I call him our OG, our original, Dr. Mark Nispeka, who is at Rady's Children's Hospital, who has been in this community for 30,000 years, 25 years. And I will say one thing about him, he actually retired, but he has continued to go and only see Angelman patients because he loves his Angelman community so much. So he continues to do the Angelman clinic because he loves you. So I'm going to stop talking because no one wants to hear from me. And I'm going to pass it over to Dr. Mark Nispeka first, I think. Thank you, guys.
All right. So today I am the appetizer, Ron is the entree, and the dessert is Rob. So what I'm going to do for those of you who may be newly diagnosed and new to the seizure world is just go over some simple ideas about seizures, what they are, different types and so forth, and then show you some videos and hopefully finish within 10 minutes. So I'm going to take my watch off and try to stay on time. So one of the questions that often comes up is what proportion of individuals with Angelman syndrome have seizures? And you probably heard 70%, 80%, 90%. So it's somewhere in that range. The time at which seizures develop tends to be between the age of 2 and 4 years of age, with an average of 32 months, just under 3 years. And that is often the major presenting feature to medical care. And I don't know about my colleagues, but one of the ways we're seeing more kids diagnosed with Angelman syndrome is kids who come into the hospital with a seizure or several seizures, have an MRI scan that's normal, and then get an epilepsy gene panel, and they're found to have a genetic abnormality consistent with Angelman syndrome. The most highest proportion is in with deletion positive patients, and the lowest proportion, as you probably heard, are with UPD and imprinting genotypes. So the terminology of seizures can sometimes be confusing. The official definition of a seizure is a transient occurrence of signs and symptoms due to abnormal, excessive, synchronous neuronal activity in the brain. And the type of seizure is defined by the type of motor or non-motor activity that's observed or reported. For example, the term tonic means stiffening, and that's usually stiffening for several seconds, 5 to 10 seconds usually. The term atonic means sudden loss of muscle tone. The term clonic means repetitive jerking. that is usually can't be restrained. And the term myoclonic is like a lightning quick jerk that I know I used to do when I had a boring teacher in college and high school, and I would be falling asleep and go like that. And that is often not a seizure in most individuals, but can be a manifestation of seizures, especially in younger individuals who have Angelman syndrome and other disorders. And the term epilepsy is applied either when there's a recurrent unprovoked seizure, or you have one seizure and have a high probability of having subsequent seizures. The term epilepsy syndrome is a sign, particular syndrome is a sign when there's a cluster of clinical findings, seizure types, and EEG findings that meet the definition of a particular syndrome, such as Lennox-Gastaut syndrome. The classification of seizure types was changed a few years ago by the International League Against Epilepsy. What were previously called partial seizures are now focal onset seizures. And as opposed to complex partial, which means that your awareness is impaired, distinguished from simple partial, where you're alert and talking while you're having repetitive clonic jerking, that was called a simple partial seizure. That's now called a focal aware seizure. And the ones where you space out and lose responsiveness is a focal impaired aware seizure. And different motor features can accompany that are on this list. Generalized onset seizures are tonic-clonic seizures, tonic seizures, myoclonic seizures, or mixtures of many of them. I should mention also that focal onset seizures can progress to develop secondary generalization, where you have bilateral stiffening and jerking. And then there's some kind of seizures where the onset of that is not known, and whether it's partial or generalized, even sometimes after they have epilepsy monitoring. And this is just a list of the former seizure classification. They're basically similar to under the generalized category, but the names for the partial ones and now focal have changed. So you'll see this in older reports, but most newer discussions of seizures in the medical literature and patient education pamphlets include the current terminology. And as I mentioned, an epilepsy syndrome combines seizure type, the types of epilepsies that are focal or generalized. And when you look at comorbidities, intellectual disability, autism, cerebral palsy, et cetera, and look at the etiology, then you can define a syndrome. So the question comes up sometimes whether Angelman syndrome is an epilepsy syndrome. My bias is that it's not, because not all individuals with that Angelman syndrome have seizures, and that can be true for their entire life. The initial seizure types in Angelman syndrome include a wide variety of seizures: myoclonic, atonic, generalized tonic-clonic, atypical absence, and fewer are spasm-type seizures, which are brief flexor lightning-like thrusts that are forward or rearward. And focal seizures tend to be less common for the initial seizure types. I should mention also that it's not uncommon that the first seizure occurs in the setting of an illness with fever in young kids. And at follow-up later on, the different seizure types tend to remain the same, except that you tend to see more individuals over time manifesting generalized tonic-clonic seizures. And this is just the range of the prevalence of seizure types from 3 different surveys of seizures in patients with Angelman syndrome. So with that, I want to go, I think we've talked about this before, but what I want to do is go directly into the video examples of seizures. So look quickly here. That is a series of myoclonic jerks along with a loss of postural control. And I would call that a myoclonic astatic or atonic type seizure. And there's not any more seizures in here, but I'm not sure I can control the length of this. By the way, all of the parents whose children are in these videos have given me explicit consent to show these for the benefit of their fellow families who have Angelman syndrome, for those who are not familiar with these. Greg, can you advance that? Go on to the next slide. Great. So this is a child who came in and had a seizure in sleep that, to the best of our knowledge, was a generalized tonic-clonic seizure and had that type of EEG feature at the beginning of that seizure. And this same child had looked very carefully about 30 seconds into this and watched this boy's eyelids moving up and down, and he's having a very brief absent seizure. And you'll see him pause very, very briefly, just for a couple of seconds. Right there, that's where he does it. It's very subtle, very brief. And that's the kind of thing that when we started out with the natural history study, I would see some kids as part of that, and some patients would have that, and the families didn't know that they were seizures. And when this is all a child is manifesting and it's rare, I don't necessarily start them on an anti-seizure medicine, but that my colleagues may disagree with that. So this is a long seizure. This is a focal impaired awareness seizure. And if the sound is working, mother reported that this always started with a gagging sound. And what you'll see happen here is that she gags and then becomes unresponsive, stares, and has some oral automatisms. Right now, unfortunately, she's looking away from the camera. I hope the audio plays of this, because the gag is what always tipped mom off to these happening. Yeah, she had, the audio isn't working, but when you saw her open her mouth, there was a loud gagging sound like, and here she's just sort of staring straight ahead, has somewhat a fearful look on her eye. She's not responding to her mother. And you can see this wide open stare, which is a definite change in her behavior, which you'll see later on after she comes out of it. You'll see a more appropriate behavior. The nurse comes into the room and asks her to lift up an arm. And the next slide is a continuation of this. And you'll see this end. And you see her having what are called oral automatisms, chewing and so forth. And she still is in the seizure now. And now you can appreciate the change in her behavior, where she's no longer staring and unresponsive. And she had an electroencephalographic seizure pattern coming over her left frontal part of the brain. And this is the final video I'm going to show you. I think this occurs maybe 20 or 30 seconds into this play. And mom is describing what circumstances she'll do it in. I'm sorry the audio isn't working. So that is her seizure. It's a brief forward flexion and a myoclonic extension of her arms, and it's very brief, and she recovers from this promptly afterwards. And with that, that is all I have to show you. And that's not a guacamole preparation. That is a pear that she has in her hand, even though she's in San Diego. So, and with that, I'll turn things over to Ron, and I'm sorry I went 3 minutes beyond.
Hey guys, it's Amanda here. As you know, we're here for you, our community. If you have questions about any topics we can discuss in our podcast, or if you have ideas for future episodes, we'd love to hear from you. All you need to do is email me at dearamanda@angelman.org. Thank you so much for listening and your continued support of the Angelman Syndrome Foundation.
So I want to talk a little bit about seizure treatments. Let's see if I can figure out how to use this. Just hit the green button. The big green, got it. Excellent. Oh, now I did it. Okay, good. So one of the things that we don't talk about a lot, but I think is super important, is that one of the best ways to treat seizures is to treat anything that could be worsening the seizures. Children with neurogenetic syndromes, autism, any kind of developmental issue, including Angelman syndrome / especially Angelman syndrome, they're prone to poor sleep, GI dysfunction, anxiety, and all of those things can worsen seizures. So when a family calls and says that, their kid's seizures are worsening, that's always first thing we ask is, are you sleeping? Are you pooping? And a lot of times that's the answer. So, before we get into actual medicines and whatnot, I think this is important to know that, when seizures do flare up, one of the key things is just kind of look, is there a reason? And sometimes there's not. Sometimes it's just how the epilepsy is, and just it was time to do that. But there's often a trigger, and treating that as well can be super helpful. So treatment options, the mainstays are medication, diet therapy, and surgical options. Surgical options, we've rarely had to go to that route in kids with Angelman, but it is there if we need it. It's mostly medicine and diet is what we use. So medications, this is a graph from a paper we did. This was a survey in 06, 07. And I didn't put it on here as a guide of what medicines to use. It was just what medicines were being used at the time. And what really stands out is that looking at it, and of course my eyes are going bad, but the third one in, the yellow one there is phenobarbital. The fifth one in is carbamazepine. A few down from that is dilantin. And these are all medications that can worsen seizures in Angelman syndrome. So even, I can't believe that was 18 years ago, but even 18 years ago, there were that many kids with Angelman on medicines that are known to actually worsen their seizures. So we've come a long way from that point. These are the medicines. So we always talk about using broad spectrum seizure medications in Angelman, and those are the medications that can treat all different types of seizures. This is a list of medicines that have been around, that were around pre 2010, probably pre 2000. I won't go into them all in detail. We can kind of talk a little bit about it later, but these are all medicines that could potentially be used to treat seizures in Angelman syndrome. They're all good broad spectrum medicines. The ones that are not broad spectrum that can are definitely known to worsen. Mentioned a couple of them: phenobarbital, dilantin, and then the whole carbamazepine family: tegretol, trileptal, aptium. Another couple of medicines that really aren't broad spectrum, but we have not seen worsen seizures, are gabapentin and pregabalin. They're more meant for focal seizures, which isn't super helpful for Angelman, but they can both be very good sleep medications. So we haven't really seen them improve seizures, but we've used them a lot to improve sleep. And by improving sleep, we often improve seizures as well. So medicines that we wouldn't use as anti-epileptics, but we use for sleep, and then that in turn can really help with the seizures. And then, so these are the newer medicines since 2010. Clobazam's actually been around way longer than that, but it's only been available in the US since 2010. Back in the old days, we used to have it shipped in from Vancouver or San Diego. They would cross the border for it, but it's been available since 2010 here in the US. Well, I'll talk about it a little bit later, but it's one of our favorites. Shortly after, Banzel and Vimpat are also good options in Angelman, one that went off the market. And then the newer ones, Fycompa, Briviact, Epidiolex. We actually use Epidiolex and Briviact a lot. Epidiolex is the marijuana medicine that is out now. It's basically cannabinoids in sesame oil, but with the THC taken out. And it can be very effective for seizures, but also we've had some teens and adults respond really well to have their non-epileptic myoclonus respond to it. And Briviact, what it is, so it's brivaracetam, Keppra's levetiracetam. So what it basically is, it's a new version of Keppra that has much less risk of crankiness. So for kids that tried Keppra, were super cranky, came off Keppra, we've retried Briviact, and sometimes they're still cranky on the Briviact, but there's a lot lower percentage of that. And then the two newer ones I haven't really used in Angelman a lot, just because we haven't gotten to that point. But Xcopri, and then the other one that's kind of covered up is Fintepla. Those are two newer medicines that had really good success in trials. I certainly would use them if we got to that point, but we just haven't had any angels yet that have failed enough medicines to go there. And then, so this slide, I just kind of wanted to point out when we did that seizure survey back in the day, so that first column was Depakote. It was, like by far the most commonly used medication. And, I think we had about 460, 470, responses to that survey. And one of the first things was, we asked for side effects at Depakote, like stopped walking. So I said, well, it's got to be coincidence. Next one, Depakote stopped walking. And there were just a bunch of those. So over the years in clinic, and you can see the side effects. So the 66% of our kids as of 2016 had side effects. So two things with that. One, it's a big number, a lot of side effects, but number two, it's not 100. So there are people that are on the medicine that don't have side effects. So it's one of those things where if you're on it and you're not having side effects, you don't need to rock the boat. But we typically don't start it, for kids just because the side effect rate is really high, specifically in Angelman, not overall. But we've had a few really extreme examples where we've had, and I can think of at least 3 kids that never walked ever, and they were 10, 12, 14, that we met them, took them off Depakote, and they started walking. So again, that's not the norm, that's the extreme end, but it can be, if there are kids that have never walked, they're on Depakote, they're older, that's always a good place to start. And the other one, Keppra, Lamictal, Clobazam, those are the medicines that we use a lot. And really from our experience, it's just because we've used them and they work. It's not that we've trialed them against other medicines and shown that they're better, but those are 3 that we use a lot that tend to work well. But newer medicines like Briviact and Epidiolex work really well. And then other meds on that list like Vimpat, Banzel, they could all be good options. But those are kind of our favorites, but there's several options, which is great. Moving on to diet therapy. So there was a whole talk about this. If you went to it, this will be a little bit of review, but ketogenic diet's been around since the 1920s. The exact mechanism is not well known, but it does a lot of things. It makes your blood more acidic. You have ketones floating around in your blood. It can alter the bacteria in your gut. So there's many ways that it does affect the brain, and there's probably some combination of all of that. The ketogenic diet is really restrictive. It's about 10 grams of carbs or less, which is not easy. You have to weigh everything. It's a typical ratio of 4-to-1 fat and protein to carbs. Fat to protein and carbs, that being mostly protein. We usually have to do a short hospital stay for a couple nights. We don't fast anymore, but it's a couple of days just to really monitor labs closely. And then we really have to monitor labs to look for acidosis, especially if you're taking medicine like tolmetrozonogran, that can even worsen it further. So we really have to be vigilant. And we typically some risks would be hyperlipidemia, bone density. So we supplement with vitamin D, calcium, multivitamin, and carnitine as needed, because the high fat diet can lower your carnitine levels. And then low glycemic is based on the glycemic index of foods. Basically how much it raises your blood glucose. And Heidi Pfeiffer's out in the audience. She was the queen of the LGIT. It allows for 40 to 60 grams of carbohydrates per day. Which, compared to 10, it doesn't sound like a lot, but it's a lot more than ketogenic is. So there's no admission involved. The meals are based on percentages and caloric needs. So there's not weighing. And it's a lot easier to be compliant with it. It works almost as well, and it's just a lot easier to do. So we typically start with that unless they're babies or have G tubes. If they're just drinking formula from a bottle or getting formula through a G tube, then it's very easy to just go straight to keto. But if not, the low glycemic is a lot easier to do, and then we can always convert if we have to. Let's see. Yeah. And this is a study that we did a few years ago, just kind of looking at our first 23 plus people that were on the diet. I kind of skipped to the bottom, but what it showed was that Angelman, LGIT was very effective in Angelman, which we really had been seeing it. It's what we see is that it works typically better for kids with Angelman than for a general epilepsy population. I don't know if it's the syndrome itself or just the parents are more motivated and do it better than others. It could be either one. But the two situations where it isn't as effective, one is non-convulsive status. It's low glycemic to treat that as we've still had kids go into non-convulsive status even if well-controlled seizures on the diet. And then with illness, we've had kids that were super well controlled on dietary therapy. They get sick and then they can still have breakthroughs. And really, when you're sick, your whole metabolism gets thrown off. You get dehydrated, so it really kind of affects the way the diet works. But overall, very effective. And the surgical options, I won't go into too much detail because we don't use them too much. But there's, the main kind of, when we think about epilepsy surgery, we think about cutting out a part of the brain where the seizures come from. So if we see that the seizures come from, the right temporal lobe, the left frontal lobe, but the surgeons will go in and cut that out. But that's really not an option for Angelman syndrome because it's a genetic syndrome. It's a whole brain kind of epilepsy. So there's not one area that will cause seizures where the other ones will not. So that's kind of off the table. So that leaves vagal nerve stimulator and responsive neurostimulation RNS. The VNS has been around for years and years. It's a little device you implant inside under the soft tissue in the chest. It wraps around a big nerve that goes up to the brain, and it gives off a signal. It's not, again, it's like the diet or some of the meds. Like, I'm not sure exactly how it works, but basically it sends an electrical pulse up the nerve, and the thought is that it kind of disrupts the seizure network. So kind of that electrical disruption kind of can prevent seizures from forming. And kind of the studies have shown that 25 to 50% have experienced more than 50% seizure reduction. So it's not curative, but it can be palliative. Like I said, we have very few angels that have VNS just because we've been able to manage them with diet and medications. But that's definitely an option if those really aren't enough. And then responsive neurostimulation is newer. It's one of those things where it's even further down the line, but it's basically putting kind of the same type of neurostimulator, but like inside the skull. And the thought was that the leads would go onto a part of the brain that was seizing but couldn't be cut out. And so you could really directly stimulate those, that region. And unlike the VNS, which just kind of constantly keeps giving off little pulses every so often, it gives this one does the same thing, but with the VNS, you swipe a magnet to activate it if a seizure is starting, whereas the RNS actually is constantly kind of running an EEG, and when it sees a seizure, it zaps it. So that's pretty cool. And it also captures EEG data. So there's definitely some pluses to it. We're starting to go to it a little bit more than the VNS. But again, we haven't really gotten to that point with an angel, but it's out there if the seizures are too tough to control through medicine and diet. And then the other piece, I think I saw a minute, that we wanted to talk about was non-convulsive status epilepticus, which is a big one. In the literature, it's about 50 to 90%. You see the 90% was just one article, but a lot of articles say 50%. We saw more like 20% back in 2018, 20 to 30. And I think a big part of why our number is lower is if you look back to that slide and you see all those people that were on phenobarbital, Dilantin, and Tegretol, that the medicines alone could have put those kids into status. But even if it is as low as 20, it's still a big number. And what happens, it's pretty much like a continuous absence seizure. It's and what it looks like is it's basically these kind of just kind of start over a day or two, like just kind of kick in, and it's basically kids have kind of altered alertness. They're not quite themselves, they're not quite as focused as it goes on. They can be more uncoordinated. Sometimes they'll eat or drink less, and you can just tell that they're off. The most common time that happens is after an illness or a long bout of poor sleep. So if you travel and they don't sleep the whole week that you're traveling, we see that a lot too. And the thing to remember is Angelman syndrome is not progressive, at least not acutely progressive. So if someone has kind of a they're doing well, and then over the span of a few days just kind of goes downhill, that's always the first thing to think about is non-convulsive status. So we get an EEG and we look for it. If it's kids that have been in non-convulsive status, we know what it looks like, and that it happens again, we don't even bother with the EEG. We know what it is. We just treat them. So the most common is absence status. There's a more rare kind called there it is. Yeah. Myoclonic status and non-progressive encephalopathies. So it's basically the same absence status, but with frequent myoclonic jerks. So their alertness is decreased, their coordination, the whole bit, but they're also just twitching a lot. It's a rare syndrome, but the most common reason for it is Angelman. In our 350, like we've seen maybe 3 or 4. So at least in our clinic, it's about 1%. So it's not super common, but it is a thing in Angelman, and it's a little bit harder to treat than the regular absence status. But it's the same concept for treatment. That's what an EEG, you don't have to know what an EEG looks like, just tell that there's lots of sharp spikes all over the brain. So it's just basically constantly just, I should move this up. It's basically just like an absence seizure that just doesn't stop. And then the treatment for that, we did a paper back in the day. We, for the, at that time we'd had 13 children with 25 episodes, and Valium, just a kind of an oral taper of Valium at home, was effective in 20 out of the 25. So about 80% of the cases we were able to just treat with Valium. And I know some people have actually asked if I invented this. I did not. The Valium taper has been around forever, but the reason we wanted to publish it because it works so well in Angelman syndrome. For most kids that go into non-convulsive status that don't have Angelman, it's a little harder to treat. They often have to be admitted, but with Angelman, they respond so well to benzos that we can usually get away with just treating them at home, which is great. And out of the 5 kids that did not respond to benzos, we moved to steroids. So basically kind of treating the non-convulsive status as what we call like an epileptic encephalopathy. There's a bunch of different types of those, and the treatments are lots of benzos or lots of prednisone. And so we kind of treated this like almost an acute encephalopathy. So we treat it the same way. If benzos don't work, steroids often do. We can either do just oral steroids at home, or if it's bad enough, we have them come in and we give a couple doses of IV followed by oral. And only 3 of the 25 kids did not respond and required hospitalization. Out of the 3, there was 1 kid twice, and then the other one was a crazy story where they came from very, very, very far away and had been in status for 10 months. But we did pull her out, but that took a lot more doing. And I think that's it for my piece. So I'll turn it over to Rob.
All right. So I'm going to discuss what to do when everything Ron talked about doesn't work. And then we'll also talk about some of the non-epileptic myoclonus and movement disorders. I'm going to skip disclosure part. I think just like any other emergency kind of preparedness, I think it's super important to have a plan. What are we going to do if this happens? We'll talk some about rescue medicines. I think of rescue medicines as, and I say this all the time, it's like a fire extinguisher for seizures. I hope in your home you have a fire extinguisher. I hope you know where it is, and I hope you don't need it. But sometimes we need it, and it's better to have and not need than wish you had. Use your experience. You know your children the best. And so, sometimes when we talk about things like seizure clusters, I can come up with a definition, but I think families are in a better position to know, he's just had 3 seizures in an hour. When this happens, there's going to be a 4th and a 5th. So this is when we need to do something. And I'll talk more. And as Ron mentioned, prevent the triggers. Now, sometimes we don't know their triggers. No matter how hard you look, you never find the trigger. If there are triggers that you do know, work to prevent those. And then I'm going to throw a plug out because Katie with the Ladder team has been working behind the scenes, and we're working on a document that can be a resource for seizure management. That I think this would be something that you could have. And if you end up in the emergency department, just say, oh, by the way, here's some thoughts. So, and in general, there's a lot of different definitions for many things. Our typical kind of seizure emergency definition is a prolonged convulsive seizure greater than 5 minutes. We'll also say if there's multiple smaller seizures, whether focal or generalized, without a return to baseline in between. And then for the non-epileptic myoclonus or dystonic movements, I don't think we really have a definition yet of what we'd consider an emergency. Of course, for anything, if there's concern for vital sign instability, difficulty with breathing, that of course escalates things more towards emergency. And again, I go back to you guys when using your experience, if somebody's having a myoclonic spell that just won't stop, and you've done the things have worked in the past and it still doesn't stop, that's time to reach out and get further assistance. So of course, these are standard things that hopefully, people have taught you. If somebody's having a seizure, lay them on their side. The key reason for that is if somebody vomits, out is better than in. Make sure they're not bouncing their head on a cement floor. Nobody can swallow their tongue, so don't try to pry their mouth open. You'll lose a finger, they'll choke on the finger, and that's bad. And and then use the rescue medicines when needed. They are very safe. So there are a lot of rescue medicines available. Benzodiazepines remain the first line of therapy. So these are the class of clonazepam, diazepam, lorazepam. Oral medicines like clonazepam can be used, for example, if there's seizure clusters where somebody has 2 seizures, but they're still awake and you're worried they're going to have a third. You can treat that orally. Now, if somebody's having a prolonged convulsive seizure, it's not safe to try to get them to swallow something. So that's where we have Diastat, which is the rectal formulation of Valium. And then now we have more availability of 2 medicines, Valtaco and Nasolam, which are intranasal versions. So you just squirt it right in their nose. Now, for non-epileptic myoclonus, a lot of the treatments actually are the same. Benzodiazepines remain our kind of first-line therapy. With the same thing, oral is good if somebody is interactive and safe to swallow. The same medicines will work for prolonged. So Diastat, Valtaco are definitely things that you can try at home. If it's close to bedtime and your child is already on sleep medicines, you can give those early. Because for a lot of movement disorders, sleep is a very good way to fix them. Now, some things that, as we've mentioned, there's some things we just don't have a lot of data for. And there's some anecdotal reports that diphenhydramine, which is Benadryl, can be helpful. We could get into reasons why that I think it could make sense, and it has some anticholinergic properties. Now, the thing to file away is theoretically Benadryl can also make it easier to have seizures. And 2, some people that take Benadryl, it's like you've given them crack. So if you've ever given your child Benadryl and they have historically started bouncing off the walls, this would not be a good time to try that again. So if you've used it and it makes your child sleepy, then that could be an option if nothing else is working. Now, when I talk about second line rescue medicines, these are the ones that would be given in the emergency department. There's a long list. Some of those, noting like levetiracetam and valproic acid, are some of our standard seizure medicines, but are available IV, so you can get big doses in quickly. And those are also ones that you don't necessarily need to stay on it, but it can help you get out of the emergency. Again, some of those same medicines, and I bring up the levetiracetam and the valproic acid in particular, because these are also medicines that work for different types of myoclonus. So those are all, again, reasonable things. And again, anecdotally, the Benadryl is also available as an IV formulation and could be an option. Again, we just don't have great data. So the most important thing, I think, in these situations is you and using your experience, because, you may be in an emergency department that they've never met you, which hopefully they haven't because you haven't had to be there. And you can say, look, this is what we've tried. And in the past, we've tried these things. And if they didn't work, somebody gave this and everything got fixed. Or, it only has gotten this bad in the past when he's been really constipated and we just couldn't fix that at home. And then, especially moving into thinking about non-epileptic myoclonus and dystonias, prevention, if able. So as we've talked, really focus on triggers. Sleep, I know we all work on sleep, constipation. If anxiety is a trigger, there's lots of things to do to improve anxiety. And then, of course, for young women, if it seems like their menstrual cycles are a trigger, there are now medicines we can use to help mitigate that as well. Now, there are medicines that we use that can also be helpful, many of which are our standard seizure medicines. And there's, my picture here is the magic bullet, which I do not have a magic bullet. And some things that work for some people don't necessarily work for others. And so some of the lists are the same medicines that we use to treat seizures. Now, I think one of the things my goal is to better understand if more of the medicines we use to treat movement disorders will be helpful. And from data that we have that will hopefully be published soon, one of the medicines that helped was trihexyphenidyl. It's an antimuscarinic agent. It has a lot of side effects. So the good and bad of it is it can help, but it's not tolerated in everybody. And then there's a variety of other medicines that I think could be helpful. We just don't have the data yet. And that's where there's a lot of ongoing work. So the summary points, if you know the triggers, do whatever you can to predict them or avoid them. Treat early. The ship reference is kind of, if we can prevent something, it's easier to stop the boat from moving than once it's moving to try to get it stopped. I'm a big fan of videos for seizures, for abnormal movements. There's things that, a lot of the thing, it's like taking your car to the shop, right? It doesn't make the noise. Well, for movement disorders or seizures, the likelihood that that's going to happen when you're in clinic with me is pretty low. So if you have a video, bring it, email it. There's all sorts of ways to get things to it. And if you try a treatment and give it a good shot and it either has lots of side effects or just doesn't work, move on and try something else. And if though there's something that works really well, make sure you tell us like, hey, we did this, whether it's a medicine that we prescribed or something else you tried. Because if it worked for your child, it may work for someone else's. And those are the things that we all want to know. All right. I think we are open for questions. I will move back to the.
Hi, I have two questions. My friend had to go to another session, so I'll start with mine. Okay, I have a son who's 8 years old. He has CTD. He had started having seizures around 3 years old. Tried to weigh it, and we've had a little bit of control, but recently we found all of the seizures are triggered by temperature, hot water, cold water, or falling. I've talked to a lot of people here, not a lot have that going on. Is that something you've seen in clinic? And is there a different treatment that maybe we should try if we've seen that before?
This work? Yep. Okay. Yeah. It's not super common, but we do see it. Kids with Angelman have they have some degree of autonomic dysfunction, so the part of their nervous system that they can't control. And for most, it's not doesn't really affect much, but for some, it's more so, and they get those kind of triggers. So I know it's tough, but they said we'll try to avoid heat, but it's not easy to do. Yeah. Where do you guys live? Okay, so that's not too bad. You're not in Phoenix, but yeah, but the treatment would be the same. Whether they're triggered by heat or by anything else, it's still the same seizure treatments. And then, as hard as it is, anything that you can do to avoid those triggers. I know you can't avoid all of them, but yeah. But he's not alone. We've seen others. Yeah. It's not super common. So if you ask 20 people, maybe one will say oh yeah, we have that, but it's
I was just going to make the point that, two of the medicines that we use, topiramate and zonisamide, can decrease sweating. So depending on where you are and where you live, if overheating seems to be an issue, it may be worth looking just discussing with your physician what medicines you're on.
Oh. Yep. There you go. Yeah, that's a great thought. Yeah. Right.
Your child's on zonisamide plus levetiracetam? Only zonisamide. Oh. Okay. 3 good medicines. Okay. And lukewarm water doesn't do this. It has to be hot or cold. Uh-huh. Really? Okay. So I'll let my colleagues weigh in on this, but there is another kind of disorder of water immersion epilepsy that is a familial epilepsy most commonly seen in individuals of South Asian descent, and many of them can respond to valproic. So if it really is a huge problem, trying to substitute that for one of the others might help, but I would do it really judiciously. And if you don't see a dramatic early response, just stop it. And especially if the child stops walking, stop it. Okay. All right.
My last question. Like, she's 4. She has never seen any seizures. She's wondering if she should just get an EEG to make sure nothing is happening.
So, and there's style points here. And I think, I was discussing this and Ron at the other, discussion said, he routinely does, a screening EEG with younger kids. And I'm speaking for you. Whereas I don't all that frequently now, because my thought is, well, what will it change? And if we're not seeing clinical seizures, I'd be hesitant to start a medicine unless there's subclinical seizures on the EEG, which I think would be unlikely. I would agree with Ron too. Strongly encourage that they have a rescue medicine.
Thank you so much.
Oh, yeah. And the Zonegran, is probably best to try. Yeah, that's a great thought.
Okay, good afternoon, everyone. And since Evan wants to use the microphone, so here we are. My question is regarding the emerging option of the use of RTMS, the repetitive transcranial magnetic stimulation. What do you think is the future of this emerging option in the Angelman community? There was a patient in the Mayo Clinic that they did the RTMS. He had 200 seizures a day. And during the process, the daily use of the TMS, his seizures dramatically slowed down. And then at the end of the 6-week repetitive TMS, his seizures were gone. So what are your thoughts about that? Is that something that Angelman syndrome can do a research on our kids?
Yeah. Yeah, I have no.
No, it's a good question. It's not something that we've tried in Angelman. They're across town. They have a TMS clinic, and I know that it's one of those things where it's when you look at the list of treatments for seizures, it's kind of like down at the bottom, but it is a potential treatment for seizures. I think the results are very inconsistent, but it working for some kids, I wouldn't be surprised if it does. But as of now, there isn't a lot of data that it would work for most kids or many kids, but it's just still, there's not a lot out there, but it is on the list of potential treatments. It's just kind of further down. And there's one clinic in Boston, but there was pretty inconsistent with does it help or not.
Yeah. So yes, so the RTMS right now is only covered by insurance for MDD, major depressive disorder, and they just added recently for approving those with obsessive compulsive disorder as well. So it's hopefully it sheds hope or light for us families with the kids with seizures.
Yeah.
Right.
Yeah. I think the clinic at Boston Children's is it's research based, so that's why you can get it without insurance. But I think if it was going to be super effective, it would have taken off by now probably. So
yes. Okay.
Yeah.
Thank you.
Yeah, and we do appreciate the help with the talk.
Sure. Thank you. And then Dr. Dr. Nispeka, I have a question because we see you at the Natural History of Angelman Syndrome in San Diego. So, Evan. So my question is, at what point, seizures, correct me if I'm wrong, seizures in Angelman Syndrome do get better when they get older, when they get to the adulthood. Correct me if I'm wrong, but that's what I thought I've heard before. And so now, at what point do we think about, or do we start weaning off slowly the medication that is on? He hasn't had seizure for years, at least 5 years or so. So what are your thoughts about that?
That's a great question. Am I on? No, let me use this one.
No.
That's a great question. And I think each of us may have our own approach to that, but I think that I'll tell you what my experience has been is many kids in their teens or young adults in their early 20s who have not had a seizure in years are often on a low dose of medication where we have not adjusted the dose upward to keep up with their growth and weight gain. And when I've offered the option of trying to go off medication, I do it extremely slowly if the child is on a benzodiazepine like clonazepam or clobazam. And by extremely slowly, I mean months. Okay. And if they're on another medication, I'll tend to do it over 1 to 3 months. But with some clonazepam, for example, I like to do it so slowly that it may take a year. But interestingly, I'll bring up the issue, and many of the families say, "No, things are going fine. I don't want to rock the boat." So I'm sure my colleagues have a different approach to that, or what? I don't know.
No, I agree, and I think some of it depends on the circumstances and what medicines. So, for example, I had a young lady come to me for the first time, and I think she was in her 20s, but was on a really low dose of valproic acid. I'm like, well, I don't know if this is doing anything, and why don't we just kind of try to clean the slate a little bit? So it all depends on what the medicine is and the dose.
Yep. Yeah. And yeah, I totally agree. And the other thing that to think about is like, do those medicines help something else? So if it's a child who's on clobazam or Keppra or Briviact and they're seizure free, but they could develop myoclonus. Sometimes you leave that. Clobazam can also help with anxiety, sleep sometimes. So if they're on a medicine that's really only treating seizures and doesn't do much else, that's an easier one to say, like, let's get rid of that and kind of decrease the meds. But some of those meds can treat multiple things. So yeah, like we had someone on a tiny dose of Depakote. We took them off and their behavior went off the rails. So we put that tiny dose back on. I had someone in their 30s who was on 1/8 of a milligram of Klonopin at night, and we stopped it and we had to put it back. So even little doses sometimes, but the way to know is to try. And if you come down, things aren't as good, you can always put it back.
Thank you so much.
Which I promise to stop rambling quickly, but and that makes a good point. Some of the medicines that we use to treat epilepsy, we also use to treat mood. We also use for helping sleep. So make sure you're aware of what medicines. Now, of course, it makes sense what medicines your child is taking, but the why part. Because, for example, if you see a new provider, they may see, oh, you're on gabapentin. Like, well, that's not a great seizure medicine. Well, we use it for sleep or we use it for irritability. So it's just a important thing to keep track of.
Are we over time? One more question. And then after that, at least I will be out in the hallway for another half hour. I don't know if these guys will.
Mine should be pretty quick. My son's well controlled. He's on Keppra for years and years. He's 21, but we just started with the Angelman clinic in Baltimore, and we moved the seizure med from from lorazepam to clonazepam. And so it's now a dissolvable one, which is great. But then I thought, oh, when we're traveling, I used to break off a little bit of the lorazepam because he would get sick and have seizures when we were traveling. And so now I'm like, what do I do about that? So is there a med that you would recommend to be able to break off for those situations where they're all ramped up and they're ready to go off the rails?
So I would say, clonazepam is one we use for that purpose frequently. A lot of times, whether children with Angelman syndrome or not, if they're sick and have a fever, we may put them on twice daily clonazepam for 3 days.
Okay.
But it can also, again, help sleep. It can also help anxiety in a pinch.
Right.
So, I think that's one that you could definitely use in the same manner.
So I was just talking to Dr. Tan, though. The one that we got was the ODT, so that doesn't break into pieces. So you have to get another one that's like a pill form. Is that what you would recommend?
Yeah, or some people manage to kind of get it broken in half, or
okay. You can still do that with those.
Or just do
type
both.
things.
Or just do two different. Yeah, you can also just do two different dose. Like you can have like a milligram and a half milligram or something like that. And if you need it for seizure, use the big one. If it's more for behavior, use the small one.
Awesome. Thank you.
Yep. And do you guys have one last? Yeah. One. Yep.
Hi,
Hello.
my name is Elizabeth. I live in Argentina and I speak English so. My question is, medication work different in positive dilation and negative dilation. What is the reason for that? Yes. Yeah, you understand?
think the reason for
The difference
The
between
difference
the
dilation.
medication from dilation positive and negative.
The medications are.
So I would say from my standpoint, they're mostly the same. I think it would be really dependent on the specific symptoms we're treating, whether it's seizures or behavior. But for most things, I wouldn't treat one differently than another.
Okay.
Yeah.
One thing to mention too, those of you who were here during the behavior anxiety session, one of the speakers mentioned that children with Angelman are very, very sensitive to medications, especially to the SSRI medications and some others. Our experience is with a medication like clobazam being used for seizures is surprisingly many kids can tolerate much higher doses of clobazam than non-Angelman patients. And so we may push that up to the point beyond what the guardrails in our electronic medical record system allow us to do. And we have to write added notes to the pharmacist that says, please dispense this higher dose. So is that your experience also? Okay.
Thanks.
I will try and make this as quick as possible. I was going through and reading through a lot of the medications that you guys had. I work on an ambulance. We have seizures all the time, but with Angelman, I noticed that you guys didn't have Versed listed anywhere on there for emergency meds, and that's what we'll push quite frequently for long-term seizures. Is there a reason why I should let my MD know, or that I should be aware of as an advocate not to push Versed if there's a long-term seizure?
So I did have Nasalam, which is intranasal Versed.
Oh, is it? Okay.
Yeah, so
we do only IV, so I didn't recognize it. Okay.
So midazolam, Versed, perfectly good.
Okay, perfect. I just
Yeah,
saw that and I was
absolutely.
like, he lives in my county. I want to be able to advocate for it. Thank you so much.
So we're going to be out in the hallway for furthers because the next speakers are chomping at the bit to get up here and tell you all about sleep. Thank you.
Thanks for listening to the ASF podcast. If you enjoyed this episode and would like to support us, please share it with others, post about it on social media, or leave a rating or review. And please don't forget to subscribe.